So I guess we could apologize for that opening motivational theme music, but have actually decided against it, as you are now wishing to become members of the Medical A-Team. First and foremost, welcome and thank you for signing up and craving the need to upskill or revise this fundamental skill, and essentially aiming to become better health professionals and practitioners. Secondly, we have no financial interest to declare, and a huge thank you goes out to the Oxford Hospitals Charity Group, without whom this course would not be possible, and who have funded our brand new training equipment. And then lastly, a big thank you to the Oxford Critical Care Department, where I fall under, and where you're going to be completing the practical component of your course. So, what was the impetus for creating this course? The urge and the reason to develop an intensive, comprehensive course? Well, obviously coming from the Latin impetunia, impetare, and I'm just making this up as I go along, I guess with vascular access, I suppose when one can walk through the hospital and you go on a kind of an IV access safari, you'd be more likely to spot a patient without an IV line as opposed to a patient with established vascular access. And this skill is indeed fundamental to any doctor's practice. I guess the statistics are even more staggering when you think about it. From literature from all over the world, you're looking at more than 50% of patients admitted to hospitals need them. We know that it's the most common invasive procedure. Many patients in ICU need a central venous catheter, and many patients with end-stage renal failure. And I understand that's last statistic is from the US, but it's alarming how many of them with end-stage renal disease actually initiate the renal replacement therapy through such a device. And essentially the principles for that are the same when inserting a hemodialysis catheter, with one or two little nuances which we'll discuss on the course. Throughout the course, you'll be provided with slides like this that demonstrate current best practice, help to design this course, and feel free to quote these papers at multidisciplinary meetings, at dinner parties, and obviously read up on them if you'd like to know more. And so enters the diva, not the disco drama queen with a bad temperament as defined by the Oxford English Dictionary, but rather the patient with difficult venous access. We've all been exposed to such patients, and will continue to be in our careers. And all of these patients here are cohorts who could be labelled as divas, and the ones where running up to them and stabbing them loads and loads of times with needles and cannulas is really not the way to go, for many obvious reasons. And then, so the benefits of completing this course and becoming highly trained and proficient in being able to achieve any type of vascular access are indeed tremendous. And essentially they're threefold, a trifecta, if you will. Firstly, better, safer, and more economic patient care and improved patient rapport. Secondly, this benefits you. It improves first attempt success and your confidence to establish vascular access. And also, as learned from the recent pandemic, when exposed to potentially infectious patients and smothered in humid PPE, speed and rapid access are key. I didn't mean to rhyme there. Anyway, and also a domino effect is something which will develop, we hope, where you'll be able to become talented enough to teach your colleagues. And lastly, in the trust and perhaps wherever you ultimately go in your careers, will mean that high standards are maintained and also that various costs will be cut. Less patient complaints, less complications ranging from, let's say, pneumothoraces, for example, from a central line insertion, infections, less equipment and consumables from repeated failed attempts, etc., etc. So, what are you going to learn? The overall outcomes of this course are to provide you with some ultrasound essentials, and then to reinforce similar principles across the three modules, providing comprehensive and evidence-based fundamentals to perform these important procedures. That'll be on the first module, which focuses on peripheral venous cannulation and also discusses a few myths briefly, and then importantly really drills in core basics shared in obtaining ultrasound vascular access. The second module's focuses on CVC insertion, including the pros and cons of each of the three sites, associated tips and tricks, some complications, additional use of ultrasound in the setting, etc., etc. And then lastly, the third module, which will focus on PICC line insertion, or peripherally inserted central line insertion. So, how will you learn? Well, I've mentioned the three modules, which will provide you with evidence-based information and gold standard recommendations. You're going to be doing a quiz. Please don't panic. Then the course itself, which will essentially be all hands-on with effective instructor to attendee ratios. And we've got a whole lot of fancy new equipment which will help really drill in how to perform these procedures. And then some fancy ultrasound machines, which are the ones that you'll be most used to seeing and exposed to. You're then going to do a post quiz and just give us some feedback so we can improve it as we go along, and any things you would like to add. Then you'll get a certificate of completion, and wait for it, some CPD, which everyone obviously loves and enjoys and is a requirement. So to reiterate, you will become vascular access masters. And ideally, you'll be swift and successful, like the mosquito in the top left image, and not like poor Betty in the bottom right image. And whichever hero or heroine with whom you identify, we like to think that you'll develop your equivalent competency in ultrasound-guided vascular access. So why ultrasound? Well, it's not just because it's a fun gadget or adjunct that everyone talks about. For peripheral veins, we can use ultrasound for any patient, but this is typically reserved for our divas. The evidence is actually pretty robust, demonstrating less requirements for upscaling to central lines in the emergency department, enhanced patient satisfaction, and faster cannulation of patients with challenging vascular access versus the conventional kind of palpational method. And what about central access? Well, this is for a few good reasons. It's safer and reduces the risks associated tremendously. For example, ultrasound-guided IJ cannulation reduces the risk of arterial puncture by about 70%, which is pretty staggering. Like I mentioned, it's faster and more reliable with high chance of first pass success. And lastly, using ultrasound to place central lines is now considered to be the gold standard globally, being recommended by the vast majority of guidelines and hospitals globally. So to reinforce these, ultrasound can visualize your procedure in real time and directly. It improves success rates overall and your first attempt ones. It reduces complication rates. It can detect unexpected variations in anatomy. It can avoid neighboring structures and identify potential difficulties like stenoses or thromboses or things like that. So I think it's important to go on a few quick tangents and debunk a few myths, which particularly relate to managing emergent and critically ill patients. The first one being for that patient who needs immediate vascular access, for example, the patient who has suffered a cardiac arrest. Often our colleagues and even ourselves might think that in these patients, once we failed to obtain peripheral access via our usual traditional anatomical landmark guided method, that grabbing the ultrasound is the way to go. After all, you would have now completed your OVAC course and you're ready to show off. Well, I'm afraid you're wrong. In these severely physiologically compromised patients where the peripheral cannulation is not possible or it's time intensive, you should be reaching for your intraosseous kit. In a nutshell, IO placement has been shown to be faster, cheaper, safer, and easier with a higher first attempt success than either central or peripheral insertion using ultrasound. And now, just to be clear, I'm reinforcing this in patients who require it and who need life-saving and time-critical medications or fluids or bloods where you failed. Is when you should be using it and playing it into the intramedullary cavity of the tibia, humerus, or sternum of that patient. This does not mean that from now on you should reach for the IO gun or drill. It's for the aforementioned reasons only. Okay, and again, here's some data to mull over. In a nutshell, any drug can be given via IO that can be given intravenously. It's the mainstay of resus when it's not possible. I've mentioned what it's great for. It's faster, cheaper, etc. You get good flow rates, and you can use more than just one. You don't just need to put one into that patient. It can last 24 hours, by which stage you would have optimized this patient and established vascular access and treated them and fluid resuscitated them as necessary. Accurate labs are those which are very useful when you're performing a gas or getting your results back. Unfortunately, the ones that are inaccurate are those, but you essentially can make do until then, and you do get a lot of information from them. This is not something we're going to be teaching on the course, but it is something that is rolled out in the trust, and I really recommend that you guys attend this course because you never know when you're going to need it. And when you're going to be faced with that highly unstable patient who just needs access. So moving on to our second myth, and this focuses on the quite widely held belief that central lines are the ideal choice for large volume replacement. I've met multiple colleagues ranging in experience who either refuse to believe this or need to be shown some basic physics in order to understand it. So let's say you had a patient with vitals like that, and you knew that from the history that he's lost a lot of blood or has had severe gastroenteritis, and you need to give this patient large volumes quickly. This is all governed by Poiseuille's equation, which essentially, be it your garden hose pipe or any plastic cannula, be it peripheral or central, that we insert into our patients, it dictates that flow is directly proportional to the fourth power of the radius and inversely proportional to the length. In other words, shorter and fatter is better. So essentially, two 18-gauge peripheral cannulas will be far better for this patient and far more beneficial and economic and efficient than putting in the central line. And if you don't believe me, well, then let's wrap your eyes around this next slide. So as a reminder, as you increase the gauge of your peripheral venous cannula, you're going to decrease the radius or diameter of its lumen. And having a look at the various peripheral cannulas we have at our disposal, remember that you can see that the flow rates decrease as we increase the gauge. To say that differently, a 14-gauge cannula has a wider diameter than an 18-gauge cannula. And for a lot of you, I'm sure that's quite obvious, but it's important to reinforce these basic principles and then build on them. So going back to that firmly held belief, if you put it simply in a critical ill patient, let's just see what happens. If you look at using a 16-gauge peripheral cannula, just simply hanging a bag of blood or fluid above the patient, you're going to get a better flow rate than if you used all three ports simultaneously of your central cannula, and all three of those is attached to a pressure bag. So it's quite impressive physics, and I think even more so is when you use an intraosseous line, if you place it in the humerus or the tibia, for example, it's still going to deliver a higher flow rate under pressure than all three lumens of a central venous cannula. And again, some of you might be sitting there in disbelief, but again, here's evidence you can respectfully ask those non-believers to put in their pipes and smoke it. Here's just a reminder of the different Venflons and peripheral cannulas we use, which is rightly revision and in more just included for the sake of completeness if you want to remember it. Last tangent, for many years and detailed in numerous texts, it has been firmly believed that inotropes and vasopressors have to be delivered by a central line. This has been challenged in recent years, and the literature to support its administration peripherally is growing tremendously, with several multi-central trials and systematic reviews published to date. In a nutshell, use of these agents peripherally does make pragmatic sense. You're going to get valuable benefits such as faster time to pressor initiation, optimizing your organ support, as well as possibly avoiding the need to put in the central line. And it's also demonstrated that complications are rare and do not carry significant morbidity. In fact, in one study of 14,000 patients that required intraoperative peripheral presses, there were no complications requiring intervention. And that's the data there. So, there's got to be a few quid pro quos and caveats to this practice, though. And all of these must be met. This is not something where you're going to just run around the hospitals you work in, putting a peripheral noradrenaline and being thrilled that you've saved the day. This is quite important. You've got to make sure, number one, that you're using the antecubital fossa or a more proximal vein. These are large veins which allow for a larger cannula and decreases the chance of puncturing the back wall of the vessel. And ideally, you want to use the biggest and most superficial one that's easy to cannulate, but you may have to use a deeper vein and cannulate this under ultrasound guidance. Ideally, you want about 2.75 centimeters of the catheter in the vein. And again, that's not a number I've made up. That's something from the literature. And that's just to avoid it coming out. Proximal veins have more subcutaneous tissue to traverse, so the longer the catheter, the better. You want to limit the time of the infusion. Consider, using these things peripherally as a bridge to something else. As the patient improves, you can stop the infusion. And if the patient doesn't improve, then it's probably then time for a central line. The longer it continues peripherally, the more chance of extravasation. And in general, the time limit advised is about 2 to 4 hours, as suggested by most of the literature. Use a dilute concentration as you can, and a small volume. So in general, 4 milligrams of noradrenaline in 250 mils of crystalloid is a safe bet. The same can be said for adrenaline and phenylephrine. but arguably vasopressin should be avoided. Once started, you want to have an observation protocol, so every 15 to 30 minutes. This ensures that if extravasation does occur, it's as small a volume as possible to avoid ischemia and necrosis. And generally for these patients, you're not going to be leaving their bedside anyway. Then you want to have an extravasation protocol. And the literature to date has shown that the incidence of complications from the administration of these agents peripherally is small and does not result in significant morbidity. However, a protocol for extravasation should be used and would include things like elevating the limb, leaving the cannula in place and sucking out as much as possible through a syringe, using a warm compress, and even some people talk about using nitroglycerin paste and things like that. So in summary, your critically ill patient, you're going to be using an IO. If you're unstable patients requiring large volumes, again, maybe an IO if it's an emergency, or at least an 18-gauge peripheral cannula is better than a central cannula. And your critically ill patients who require inotropes or vasopressors, you kind of make sure that it's not immediately give the patient a central line. You can have peripheral cannulation and initiation with a bridge, with obviously those caveats I mentioned. And often, you'll see it in certain parts of the world, and certainly in OUH, where we use metaraminol peripherally as a bridge to optimizing the patient to something else. So, moving on. Module 1, Introductory Principles. So, ultrasound mechanism in a nutshell, well, you're going to have electricity, which is applied to piezoelectric crystals, creates sound waves. This will then be reflected from an object and work in reverse to give you a live image of black, white, and various shades of grey. If you aren't already familiar with these terms, it's important to start acquiring and speaking the language of ultrasound, so the echogenicity of the structures. So using some examples, here you can see the spleen and the left kidney. They look isoechoic, in other words, they look similar to each other. You're going to have the liver, which here appears darker than the kidney, so it's hypoechoic. You're going to have hyperechoic, something that's brighter, and today and in other modules we're going to be showing you things like the hyperechoic pleura, which we'll discuss on the course in detail. And then you've got anechoic. Here we've got a bladder, but fluid in ultrasound is anechoic or black, and in our course, black is blood. Remember that you've got different ultrasound probes available to us. The one we're going to be using is the linear probe, which is this one over here. It's got the nice flat surface, and it's essentially just the higher frequency one. It's going to give you great resolution, but limited depth. For those who like graphs, this is something which will help you understand this, where essentially with the linear probe, you're sacrificing depth for extremely accurate images, which is what you want for this kind of procedure. So there are multiple movements you need to be aware of, and these terms can be added to your ultrasound vocabulary. Of note is rotating, which is particularly useful when moving from the out-of-plane technique to the in-plane technique. Don't get all fussed right now. That's something which we're going to be showing you shortly. And these are the kind of terms that will be reinforced on the course, and when you have your instructor or when you may be training your own team, that you would use, so they understand what you mean when they're busy trying to achieve cannulation. Another thing which is quite important is the probe marker in vascular access, and I guess any ultrasound really, and that you want to confirm before you proceed. And then it'll show you and help you orientate on the screen where you are, so that you know where your needle's going to be coming from, or which structure could be which anatomically. So kind of wrapping up with your introductory ultrasonographic principles, you've got to know some basic buttons, and your knobology is really important. You don't want to be that person who arrives at the bedside, calls for the ultrasound machine to save the day, and you don't even know how to turn it on. So we'll show you on the course where that is, and it's really important to develop a knowledge of the inner workings of your own machine that's at your disposal. 2 modes are available, or that you're going to become familiar with, I should say. Your B mode, or brightness mode, which takes a 2D video feed of a 3D structure. Another one you'll become more familiar with is M mode, and it's got multiple applications, but in this course it's going to be used to evaluate for a pneumothorax, and we'll show you how to do that. Your probe and preset, different machines allow you to bounce between the probes and the different presets for each probe itself, and again, that's something we'll show you. And then gain and brightness are your friends. You want to use these to really optimize and improve the resolution of the image and the structure you're trying to evaluate and potentially cannulate. Gain refers to your brightness, and depth, you obviously don't want something that's too deep, where you're just sending ultrasound waves deep into the body, waiting for them to be reflected back, because that's just a waste of the machine's time, but it also gives you a poor image. And you can see here that the depth markers will be on the side of the screen. Two additional kind of more advanced principles, I suppose, which we're going to show you and introduce you to, are color and pulse wave Doppler. And that those are things which are really building on your ultrasound knowledge, which I said we would do. But I think for this, it's actually quite important. And just importantly, for the BART principle, is that blue is away and red is towards. So blue doesn't mean that you're looking at a vein and it's filled with deoxygenated blood. So you can see in this example that pulsatile round structure is blue, and that's actually an artery. And next to it, that more ovoid red structure is the vein. And if you angle your probe in slightly different directions, the color will change. Okay, so like I said, it just refers to direction. It doesn't refer to the color of the blood. And then pulse wave Doppler, which essentially allows you to sample velocity at a certain point, and then it'll help you work out whether this is a vein or an artery. But that's really when you're really struggling to identify whether this is an artery or a vein, and we'll discuss that. Again, it's obviously important to understand the general layout of the human vasculature. I'm sure you're surprised how many people have veins and arteries that vary from the anatomical textbook norm once you put a probe over that region. And I'm sure you're all thrilled to know that your anatomy has now come back to haunt you. And obviously when you perform your pre-procedure mapping scan, you're going to want to know where your anatomical landmarks are. Where in general would you find the subclavian vein and things like that. And obviously you want to know the difference between a vein and an artery. It goes without saying that incorrectly cannulating a major artery and then dilating it would be rather unfortunate. So how does an artery differ from a vein? Well, a few reasons. Veins are thinner walled, they're more ovoid in appearance, there's good respiratory variation with their diameter, they're not pulsatile, and if you fancy, you can use pulse wave Doppler to confirm this, which we'll show you on the course. And importantly, they're entirely collapsible. Lack of compressibility suggests that there's a lesion within the vessel, most likely a thrombus, which may or may not be visible. And a cannulation of that would obviously be pretty disastrous. And that you can actually see in this video here, the individual is trying to compress the internal jugular vein, and in actual fact there's a big thrombus sitting there. And that's obviously something you'd want to avoid. So, lastly, and herein lies the crux of pretty much all ultrasound-guided needlework, so I'm going to spend a little bit of time in this. You obviously want to explain things to your patient and obtain consent, and that's paramount. You want to position things, so not only your machine, you want to have it, and that you want to have in your line of sight. That's really important. Don't have it where you see people often, and the same goes for guys who try to do intubations, where they've got the video laryngoscope and the machine is slightly at an angle, or even right angles. It's very difficult in your mind to correlate what you're doing and using your hands, mind, and your eyes how to do things. It's don't make your lives difficult. You want to position yourself as well. Don't assume every time it's going to be quick and easy, and then you end up struggling with your back hunched over, or your setup just being ergonomically quite poor. Raise the level of the bed if you can, for say, for example, the internal jugular. Maybe even get a chair if you can for your peripheral venous cannulation. Set yourself up for success. Remembering to brace both your hands, having the needle in your non-dominant hand and the needle and the syringe in your dominant. Position your patient as well. So put their arm on a table if possible. Raise the bed, as I've already mentioned. Make use of Trendelenburg if not contraindicated for your IJ cannulation, or frog leg for your femoral, which we'll touch on shortly. Sterility is something we'll deal with later and is very crucial. Map out things beforehand. So don't just get all gloved up and ready to go and you find out, oh wow, this guy's actually got a thrombus, or this is going to be very difficult to cannulate, I should aim somewhere else. Mapping it out is really important, and it helps to ensure that you avoid other structures, and you can do this obviously prior to puncturing the skin. And that's really important. And also give you an idea of how deep you need to go. M-mode or central line is some of the functions that exist on these machines, and here's an example of it. You can see here That center line goes right in the middle of the screen. That correlates with the center of your probe. Here that we've now moved on to M mode, which gives a solid line. So if your machine doesn't have the center line function, and that's really useful because it'll line up the center of your probe with the center of your screen, which you can then line up with your needle and make it as accurate as possible. Pulse wave Doppler, again, that's important, like we said before, for the reasons we mentioned. And just really important is you don't want to be that person who loses sight of their needle tip. It's really important that you know where your needle is so that you're not just kind of presuming you're probably in the right place. That's kind of inappropriate and kind of defeats the purpose of being able to directly visualize in real time what you're busy doing. A few more things post-procedurally. If you're ordering a chest x-ray, that's really important. You want to flush all your central line ports. And a few other things. Don't be this guy who leaves the probe lying around covered in blood. Dispose of your own sharps. And make sure that if there are any checklists and things you need to do, you need to complete those and also make an accurate documentation of what you've done. Now, moving on to the approaches. And these are just fundamental to any ultrasound-guided vascular procedure. So you've got the in-plane approach, which, where the needle is kind of parallel to your probe and also referred to as the long axis, depending on what text you read. And then you've got the out-of-plane approach, where your approach is perpendicular to the probe. And these are terms that define the spatial relationship between the needle and the probe, and essentially how your needle approaches the target vessel. So, first up, you've got the in-plane, parallel, long axis, depending on what you read. And here the long axis of the probe, again, is ideally lined up with the long axis of your needle shaft and the long axis of your target vessel. So this is the kind of thing it looks like. You can see there's somebody using a portable ultrasound device that they brought with them. And this is what it'll look like on the screen, where you now can see your entire needle shaft and the needle tip, and your vessel will look like a long black pipe. And these images and videos are going to kind of further give you a better idea of what you're going to be performing and what you need to kind of get used to. And again, you're seeing the whole needle shaft, and you're visualizing the whole process as you go along. And there are benefits to this, which we'll discuss shortly. And this is what it'll look like when you're doing your central line insertions, and you can visualize your guide wire within the vessel before you dilate it, which is a good safety measure to do and always do. And so now moving on to the out of plane, or in some texts known as the perpendicular approach, and the one more commonly used by us and more kind of in vogue, I should say, these days is the short axis approach, which is one which I'd really recommend mastering early on. And it's kind of the best way to proceed initially in your careers of ultrasound guided venous cannulation. So what does this look like? Well, here you can see the individual's got the butterfly probe, and on the right there you've got this simple linear probe, which again has the highest frequency and so the best visualization, but the limited depth of somebody's upper arm. The tourniquet is applied nice and high up on the arm, which is really, really important. And the probe is perpendicular to the course of your vessel, the result being you're going to have this vein which is round in appearance, like a little black or little chocolate button, and your hyperechoic needle tip, which you would follow with sequential needle tracking. Just some more images to see what this looks like. Here using the gel blocks that you're going to have in the course. And that kind of shows you exactly what it's going to be looking like. And this is actually an out-of-plane picture of a very large vein, probably actually a central vein, but you kind of get the idea of it's the same kind of principles. And here I'd actually even criticize my own image here, because you can see that the one thing that hasn't been optimized is the depth, which is something you really want to master before you proceed. And that's or should I say optimize, I apologize, is your gain, your depth, and obviously mapping out your targets before you kind of glove and sterilize, etc. And again, I mentioned center path before on some of the devices, but if you don't have that, you could use M mode as a surrogate. And the idea is that you optimize your procedure to line things up accordingly. And that's exactly what is done here. You can see the center of the probe lines up with the needle, and that's really beneficial. Now, Importantly for the out-of-plane technique, be it for peripheral or central cannulation, is this really crucial principle. That is essentially never losing sight of your needle tip. Some texts and gurus refer to this as needle creep, or leapfrogging, or sequential needle tip tracking, but if you want to call it, it essentially involves finding your needle tip on your screen, then advancing your probe away from you and losing sight of your needle, then advancing your needle again until it appears, and then repeating this steadily until you're in the target vessel and you have appropriate backflash of blood. Bearing in mind that backflash of blood doesn't necessarily mean that you're right in the vessel where you want to be. That just means that you've touched a vessel at some stage during the procedure. So again, using ultrasound to visualize it step by step is really useful. And what would this look like? Well, here you can see it in cross-sectional view, which you would see on the ultrasound screen in short axis. You would then advance your probe, you lose sight of the needle tip, then you advance your needle, and you're going to see it now on the wall, or just outside the vessel lumen, I should say. Then you're going to advance your needle and your probe sequentially until eventually you are in the exact right spot that you should be, and you've successfully cannulated your vessel. So, some people ask, well, which one? Like many times in life when we're faced with a choice, some of you might be asking, well, do I use the in-plane approach, or which where the vessel looks like a black pipe, or do I use the short axis view where the vessel looks like a chocolate button? And essentially this depends on you and your level of skill, but what we'd recommend and what most experts use is a combination. And ultimately it will be up to you, but this is what we do recommend. Giving you a quick idea of summarizing and comparing the two with the in-plane technique versus the out-of-plane technique. In-plane, you can see your needle, less likely to back wall, in other words, go through it and through the other side. Can be quite technically challenging at first, however. And always remember the probe markers pointed towards the patient's head, which we'll reinforce in the day. You're the out-of-plane, better to identify your vessels. It's easier for your hand-eye coordination. You're less likely to cannulate an artery, which is obviously very beneficial. But you can't see the tip of your needle always. And that's where the sequential needle tip tracking method is what I mentioned. And here you would have your probe marker towards the right. So what I would do, the resounding recommendations in the literature and from experience and the guidelines is as follows. And that's using both. For your initial cannulation, be it peripheral or central, you're going to be using the out-of-plane technique. Okay? Following which, you're then going to be advancing your cannula with the peripheral cannulation, or assessing your guide wire location in central line cannulation in the in-plane approach. So just to reinforce that, initial cannulation, be it peripheral or central, you're going to be using the out-of-plane approach. Then to advance your cannula in your peripheral cannulation, you're going to be using in-plane, or when you're assessing guide wire location for your central cannulation, you're going to be using in-plane as well. The only exception, that's why I put an asterisk above the initial cannulation, and which we'll deal with in the second module, is for subclavian vein cannulations, where the out-of-plane is used to find your vessel, but then the in-plane approach is used for your actual cannulation, and we'll discuss that in detail on the next module. So now, we've gotten to the end of module 1 really, and to summarize, so far we focused on basic ultrasound principles in general, and we've also referred to those that pertain to any kind of vascular access using ultrasound, but now specifically for peripheral venous cannulation using ultrasound, we've reinforced a few things, when not to use it and when you should rather go with an IO. But I think there's also a couple of contraindications which should be reinforced. And I think, just briefly speaking, this is the kind of arm you'd want to practice on. But remember, in an emergency, this is not the one you're going to pick up the ultrasound probe unless you're equally as quick. And with time and with practice, you'll get even quicker. There are no absolute contraindications. Perhaps for the ER patient, I've already mentioned, they're more kind of rather relative ones. So. And this is not an exhaustive list, but these are all things that are listed in the literature. But again, you're going to use clinical judgment, must be used to balance the risks and benefits before proceeding with line placement in these patients. So moving on to the equipment, it's the same essentially that's required for any peripheral cannulation performed with ultrasound, just with a few additional tips and bits and pieces. First of which is your tourniquet site. You're going to want this as high up in the arm as possible, typically just under the axilla, in order to be able to access the more proximal vessels. Now, sterility in gel, this is quite important. By all means, when you're busy mapping out the vessel and looking for your potential targets, use these bottles of gel that you find around the hospital, and sometimes just standing on the ultrasound machine, that's no problem. But when it comes to cannulating peripherally, you should be using these sterile sachets, and you might find that with time, you might not use these bottles at all, but they should not be used for when you actually go to the needle puncturing of the skin. You might start carrying sachets around in your pocket, which is absolutely normal because you're going to become more addicted to this practice and to learning more about ultrasound. And additional things you might do is, you're not going to have to use those long probe sleeves to do this. That's not necessary, and it's not stipulated in any guidelines. But putting a simple dressing or tegaderm, whatever you want to call it, over the probe is really nice. And obviously now, once you've done that, don't go down, touch the top of it, because you've kind of defeated the purpose. And the reason why I say you should not be using those gel bottles for when you're actually performing skin puncturing and the procedure itself, and that's actually advised by a number of guidelines, and some of the literature is actually quite alarming what they've grown when they've sent those bottles of gel to the lab. So just don't do it. Right, so you're pretty much ready to proceed. You've collected all your equipment, but there's just a few things you really need to ask yourself before you, in your own mind, and kind of going through your own internal checklist. And that being kind of, where is the target vein? Which one am I aiming for? And by all means, you can use these ones initially, because if you think this patient might have or need a PICC line, ultimately those more proximal vessels are what you're going to be using. But getting practice is obviously a good idea. You've got to ask yourself, is it patent? You've seen this picture before, and you can see there that vessel is certainly not patent. This is obviously a central vessel, but you may well find a number peripherally that just aren't good choices. Okay? You've got to look at the course. There's no good finding a vessel that looks nice and patent, and you haven't actually mapped it out and find that in this particular patient, the vessel kind of is very tortuous and bends in weird and wonderful directions, so that when you advance your cannula, it just it fails. Is it an appropriate size? Okay, good question, and this are numbers that you should just burn into your head. Number one is the diameter of the vessel. It's got to be at least more than 4 millimeters of diameter, and that will show you how to measure that on the screen. And that's to improve your chance of success. Anything smaller than that, it just won't work. And that's very evidence-based. Then you've got to ask yourselves, how deep am I going here? There's no point in identifying a vessel and thinking, great, this is going to be easy to cannulate. You then do cannulate it, and as soon as you release the tourniquet, or you go away at tissues, and then you're starting all over again. The number here is you want something that's quite shallow. So the maximum being about 1.5 centimeters is what you would be targeting. Obviously, in an emergency or in some patients, you might have to modify that and use your own clinical acumen. And again, that's very evidence-based. And you're also going to use your ultrasound, like I said, to look for nearby structures. So, using this example here, you can see that your targets would, being your deep brachial vein or even your basilic vein, were good choices. And you obviously want to be avoiding things like the brachial artery or the median nerve. So the steps, remember, sequential needle tip tracking is what you want. You're going to use a combination of out of plane and in plane, like we discussed. And the best way to go about it is you're going to go in a hyperacute angle with your needle, and then you're going to flatten, okay? And that'll look essentially something like this, where that'll help you to cannulate your vessel appropriately and not kind of backwall it and ruin that vessel for immediate use. And guys, it's just not rocket science. You'll read a number of texts, and a number of gurus will say things like, you should be using mathematics. Your medics and your intelligent people were using the principles of a right angle triangle, where if you've got the distance from the probe to the needle and from the probe to the vessel, or using A and B, then C, which is the distance you're going to need to insert the needle, will be 1.4 times A. By all means, if you want to use that, guys, but I think it's just there are much easier ways, and this is not rocket science. And the more you practice, the more you'll be able to finesse and be able to do this yourselves without doing this. So what does this look like? Well, here's an example where the person's mapping things out. when you're starting off and you've got your deep brachial vein. And he's mapping now more proximally. And notice there's not even a tourniquet here, where the vessel would be a lot more plump with a bigger diameter to make things easier. And again, I would improve the depth there. Moving on to the cephalic vein. And I would even so far say that my colleague here didn't use the best gain settings either. You want to optimize this as best as possible. And then lastly, your basilic vein, which is often a ward favorite when you're really struggling and there's a patient who needs that essential IV medication late at night. So, I have much better success rates with the short axis or the out of plane technique, which again is the one I tend to recommend for peripheral cannulation. And I've reinforced, some people often mention, I've seen a backflash, so I knew I was in. And they use that to guide them. And again, this simply means you've touched a blood vessel at some stage, and that doesn't indicate your depth or appropriate location. And again, you're using ultrasound for sequential needle tip tracking, and that's what you want to do to show you where you are in actual real time. Here you can see the individuals now to rotating the probe 90 degrees, and you're getting that black pipe appearance that I mentioned prior to cannulation. What are these things? Look like in real time? Well, like this. And on a side note, again, I'd say this image isn't optimized. I don't want to sound like a school teacher, but in terms of depth, and perhaps not so much in terms of its gain, I think it's a bit too bright, but the depth might actually be adequate. And guys, going on to some complications, obvious ones, so things like infiltrations, so medications or IV fluids that leak out due to an improperly placed catheter. You've got thrombophlebitis, which is inflammation of that vein due to trauma during the IV insertion or leaving it in for far too long. Extravasation, which again is similar to infiltration, but these are the ones that are irritating and to the body. Obviously nerve injury and arterial puncture. But again, using ultrasound, this is why you're going on this course. You're going to be able to avoid these, and it's shown, and you're going to add to the body of literature of the reduced rate and incidence of complications. Lastly, a gentleman Ebbinghaus, who developed a famous curve in 1885, which is the last point I want to make, and it relates to what you're learning and how you need to get practice and keep revisiting these principles, which seems quite obvious, but it's amazing that he's actually studied this. Remember that the lower the skill, the higher the rate of complications, and that's why you're here. The more you practice, the luckier you get. You can see here you're now on day 1, and your craniums are expanding with knowledge. And ideally, these skills need to be revised and practiced repeatedly and within a short time frame in order to stay at least on the green line or preferably on the blue or even the orange line. You don't want to be in this black line here where you haven't done anything, and realistically you've lost a lot of information and you haven't retained anything after even as short as a couple of days. And again, you want to be on this orange line. That's where you want to go out there and get your practice. You don't want to be that guy who doesn't persevere and reach expert level with knowledge retention. So in summary, guys, ultrasound vascular access, remember those with difficult access, your divas. We know that it's safer, and we've gone through the benefits. We've gone through the myths that are useful to remember, and to be honest, are common exam questions as well for those who are going to be taking their finals. In general, the basics of ultrasound. You gain depth of your friend, making sure you use gel to remove that air interface, because ultrasound hates air. Sterility is really important, and we're going to go through the modes in the course. For both peripheral and central cannulation, you've got to know your sonoanatomy, know the difference between a vein and an artery. Remember your steps pre, intra, and post procedure, and don't cut corners. Remember the depth and diameter I mentioned, guys. So you want something that's at least 4 millimeters in diameter, and the depth you want to be at less than 1.5 centimeters or 15 millimeters. Approaches, we spoke about in plane and out of plane. And then your sequential needle tip tracking. Don't lose sight of your needle tip. That's really important, guys. And then obviously the contraindications and complications, which we touched on. And that's that. Thank you very much, and please enjoy Module 2.